So while we are waiting, I would introduce my colleague, Dr. Piyush Varshne. He was with me in SGPGI. Then when I came here, he was here. And now he's in AIMS Jodhpur. And also have joined is Dr. Rajen Desai from Ahmedabad. He's a regular faculty member in our morning session, which we do on Saturday.
Hyderabad, sir.
Tutorial. Sorry.
Hyderabad.
Yes. I was thinking of Avinash. Avinash is from Ahmedabad. He offers all the technical support for these online activities, he and his team. So Himanshi represents him. And I see Dr. Shahidur Rahman. He's a very senior surgeon from Bangladesh who has joined. I met him recently at Asia Pacific HPB meeting. And of course, there are a large number of colleagues who have joined, mainly from Africa.
Good afternoon, sir.
So in fact, the response from all of you, the faculty, to contribute to this program has been tremendous. And I was just thinking whether we will have to increase the frequency from once a week to maybe twice a week, because there are so many of you who are waiting to talk to the surgical students. So in this, two of my colleagues, Piyush and Dr. Kailash Kudia, he is also my former fellow from SGPGI. He is an assistant professor at AIMS. He also is helping me. So Piyush is mainly handling the faculty and interacting with them, and Kailash is mainly coordinating with the students. And I think Kailash last informed me that we already have more than 100 people who have joined the Jaipur Surgical School group. Of course, not everybody is able to attend every time, but we usually have about 20 to 30 people attending. Good afternoon, everyone. Welcome to the Jaipur Surgical School. This is an online education portal that we have recently started, mainly for students in low and middle income countries, and especially from friends in Africa, because recently I met many of you at the Asia Pacific meeting, where you expressed a desire to have such an online education portal. When I informed you about the Saturday morning session that we do, which is called Jaipur Surgical Tutorial, which is done 9 to 10 a.m. every Saturday. So those of you in Africa who are early risers, they are most welcome to join that, because I know it's very early morning for you. But I think students in Nepal are already joining Jaipur Surgical Tutorial, and they can join this also. So before we start, just a few announcements. Since the topic relates to cholecystectomy, please send me a mail, vkkapoor.india@gmail.com. I have put it in the chat also. Write Safe Cholecystectomy in the subject. I will send you the soft copy of my book on safe cholecystectomy, which has been published by one of the Indian societies, which will help you to make and keep a cholecystectomy safe. And also, all those who have joined the WhatsApp group, we will keep you informing about the master classes that we organize. So the next master class will be on Thursday and Friday this next week, 7 to 9 p.m. Indian time. So there is a link where you can join, and then once you join on that link, you will receive the Zoom link to join the master class. So with those two introductions, I would start today's session. So today's session is going to be chaired by one of the senior most GI and HPB surgeons of the country, Dr. Professor Surendra Mathur, who is globally renowned authority on portal hypertension, especially in relation to gastric varices. And he has keen interest in not only HPB surgery, but in education and teaching. So I requested him to kindly chair this session, and he very readily agreed. And the talk is going to be delivered by Major General Kamarjit Singh, who's one of the senior most surgeons in the armed forces of India. He's currently at the premier army medical institution in Delhi, and he has received one of the prestigious honors of the Indian Armed Forces, the Vishisht Seva Medal. He also has deep interest in GI and HPB surgery, and cholecystectomy again is very close to his heart. And he volunteered to cover this aspect. So with that brief introduction, over to you, Dr. Mathur, sir, and then KJ.
Thank you, Professor Kapoor. Sorry, I won't call you Vinay here. Okay. I think without delay, we first start the lecture by Major General K.J. Singh Saab on the anatomy of the biliary tree, which is, I think, is a hallmark for not only surgery, but also for prevention of all the associated injury which we are talking about.
Can I share my screen, sir?
Yes, sir, please.
So even before I start, can you hear me, sir?
Yes, you are audible.
Hello?
Yes, sir, you are audible, sir.
Okay.
Yeah, please go ahead.
Before I start the class, welcome all my dear friends from India and abroad. It's a pleasure being given an opportunity to speak to you. I want to acknowledge the lifetime dedication of teachers like Professor Mathur, Professor Kapoor, and to give me an opportunity to speak on the forum, and for such a nice introduction, a lot of it which I don't deserve, possibly, by Professor Kapoor. These people have been, their forte has been training and academic education, and they've really raised the bar. I have attended 2 of the Jaipur surgical festivals, and it's been an amazing experience. So with that in mind, I'll move ahead with the presentation. And this is one of, as Professor Mathur said, this is one of the commonest surgeries that you all will be doing. And hence it is very important. And to give you, this is my institution, Army Hospital R&R, the apex medical institution of the armed forces. We have about 1,200 beds covering all specialties and super specialties. And Dr. Vishal, because I have borrowed some from his and Professor Kapoor's book, because they made my job easier. And although I've taken a few videos and photographs from the surgery, which I've done in the last few days also. So why are we discussing this? It is one of the most common surgeries performed worldwide, with over 1 million surgeries being done annually. This is a rough figure because the exact number is really not known. And approximately over 1 lakh surgeries are done in India, or 0.1 million done in India every year. And normally we speak of the anatomy related to the to the biliary complication or the biliary vascular complications. But I would like to point out that non-biliary complications can be more disastrous. And as you can see, although the duodenal injuries are 0.05 to 0.14%, depending on who's performing and how complex the case is, the mortality rate can go up to 75%. So, although some teachers miss out on they don't give adequate emphasis on the non-biliary injuries, it is never enough to re-emphasize the importance of looking into this particular aspect of the anatomy. And the colonic injuries, which account for about 0.03%. Now, going to the biliovascular, over a period of training, as we have learned in various lectures, the incidence of biliovascular injuries has not gone down because newer people are operating, the systems are changing, probably they're not being adequately trained, equipment, the HD is not being used, or multiple such factors. And it is almost 10% higher than open cholecystectomy still. Also with lap chole, we see injuries which are more cranial. They are near the bifurcation. They are more complex because today people are using more thermal devices, and that is leading to more complex injuries. Now, complications, as I said, they cause prolonged morbidity, decreased overall survival, and significant potential for litigation. And the most important thing is that they are preventable. And the right, this animation which I have shown, or this figure which I am showing, is that of if anybody can guess, it's of a biliary cripple. So this is what a person can become if these injuries are unattended or not attended to, or not prevented. And as has been pointed out, the best strategy is prevention. And no better way to prevent than a good understanding of the anatomy, or the lack of regular anatomy, or the variations and understanding of the variations. So in making a lap chole safe for both the patient and the surgeon, for the patient, of course, for the complications, surgeon for the litigations, one of the most important aspects is to understand the anatomy. Okay, in understanding the overall anatomy, these 4 P's and 2 E's that I have brought out, they are very important. And anatomy cannot be understood in isolation without having to resort to these things in any lab colleague. So unless you position the patient well, that is head up and right up, have the proper port placement, the parameters like the pressure, the insufflation is adequate. If you're using a suction and then the pressure is low, you'll not see the anatomy properly. Or the gallbladder is inflated and you don't decompress it, you may not see the anatomy properly. If you don't peek around and use a proper camera, preferably an HD product, we recently acquired a 4K. It makes a huge difference. But today, we should not be operating without at least an HD system. And the 2 E's are ergonomics. Unless your hands are properly placed, your instrument position, and you're not comfortable with retraction and all. And if required, extra ports are not used, then you can land up in problem because you won't be able to see the anatomy properly. So this is a picture of this is the case which I did in the morning because I wanted to pick up a few pictures. And as you can see, the abdomen is underinflated. This is 7. And if you can see, the stomach is distended. So this patient requires a view, and the gallbladder is also distended. So the 3 things are: first is to optimize the intra-abdominal pressure, unless there is a very severe contraindication if you operate at a very low pressure. Decompress the gallbladder, and even before that, decompress the stomach using a Ryle's tube so that the area is better visible and the omentum comes down, and position the patient head up and right up so that everything comes to view. So this is exactly what I have done. I have positioned the patient well. I have decompressed the stomach using a Ryle's tube and decompressed the gallbladder using a needle. And as you can see, automatically, even without the retraction so far, the anatomy is much better. The colon has come down and the duodenum has come down. So in the regional anatomy, in the non-biliary injuries, the 2 most important things, as you can see, one is the hepatic flexure and the early part of the transverse colon, which is caudal to the fundus of the gallbladder. And in inflamed cases, they can be quite badly stuck. And as I'll show you a case in the subsequent slides. And in the medial aspect, near the body and the body of the gallbladder and the neck, you have the duodenum, and it can be very badly stuck. So these structures are very important, and generally they are covered with the omentum when there's inflammation, adding to the complexity, and you can't see the entire thing even without taking them down very carefully. So this is how the initial picture may appear, where the duodenum is stuck up, pulled up into the gallbladder. The whole thing may be covered with omentum, as can be seen in the left lower slide. And this is a very challenging case done by an extremely competent colleague of mine day before yesterday. You can see the omentum has been brought down, gallbladder is inflamed. And then he found a cholecystocolic fistula because of the very astute dissection, which was divided with the help of a stapler. And as he dissected more, he found a cholecystoduodenal fistula. And this was divided with a stapler. And then this was obviously the gallbladder was open because there was a fistula, and this was the large stone with the xanthogranulomatous kind of picture. So this is to show you the importance of identifying the colon and the duodenum. Otherwise, the mortality with injury to these structures is huge. Morbidity and mortality is much more than that of a biliary injury. Now, in going on to the local anatomy, in understanding close to the gallbladder, the idea or the aim is to identify, securely ligate and divide the cystic duct and cystic artery and dissect the gallbladder from the liver before retrieving it. So in doing so, what are the things that we need to know? Okay, so as the 4 P's and the 2 E's, they stand as is. Another P which I will add is the proper retraction. So I'm making it a 5 P's. So making it a total of 5 pieces. So the fundus needs to be retracted cranially and towards the right shoulder or the right side of the diaphragm, and the instrument holding the infundibulum or the neck of the gallbladder needs to be retracted towards the right iliac fossa, not with too much of force, because that can cause a kinking of the CHD or the CBD. So even before we start looking at normally we start talking of the hepatocystic ligament or the hepatocystic triangle rather. Even before that, what I have noticed is we must look at the hepatoduodenal ligament. And the first view of this area tells you where the CBD is, where the cystic duct is, where the hepatocystic triangle is, and an idea of the structures there. And a very important mark, which when we do biliary injuries, when we do a hepaticojejunostomy, is to palpate the hepatic artery. That gives us an idea in a very inflamed kind of a situation. So we can see the hepatic artery pulsating over there. And that gives you an idea that you have to remain to the right of this structure. So here again, you can see the retraction is not proper, but you can see the hepatoduodenal ligament, and the CBD can be seen going into the duodenum. And with proper retraction, here you can see that you can make out the, if I can use the pointer, and here is the CBD, you can see it going into the duodenum. And this is the area of the hepatocystic triangle. This is the infundibulum and the neck of the gallbladder. So this view, and you can see on a live, in vivo or in the recording, the hepatic artery pulsations here. So this idea gives you, this is the area of your interest and you have to stay away. And as is the teaching, you should never try and identify the junction of the cystic duct and CBD unless it's a merices or the cystic duct is actually absent. So going ahead, we come to the hepatocystic triangle. And this normally is the area on the undersurface of the liver, as you can see. On the right side and superiorly is the liver. Medially is the common hepatic duct, and caudally is the cystic duct. The contents are the cystic artery, which is a branch of the right hepatic artery. And sometimes a variable amount of the right hepatic artery can come inside, especially in a Moynihan's hump, which I'll be addressing later. The area beneath the artery and the cystic duct is called the Callet's triangle. So normally there is a tendency to confuse these things. We generally operate in the hepatocystic triangle. In trying to isolate the cystic artery, we have to go below and above it, being careful not to damage any structure superior to the artery, staying very close to the artery. And then below, between the cystic duct and the artery, in an order to circumferentially surround the artery and clip it. The other structures in these contents of this triangle are the cystic lymph node, the lymphatics, and a variable amount of fibrofatty tissue. So moving ahead, what are the other structures which help us identify? This is another view of the hepatocystic triangle. As you can see, the lymph node is here, which I'll be addressing, which is another mark. This is the artery, superior to that, inferior to that. And this I have picked up from the net. This is the Callet's triangle, and this is the complete thing is the hepatocystic triangle. Another important marker is, as you look to the gallbladder and just to the right of the hepatoduodenal ligament, this is another very important marker and very generally a great guide to the cystic artery. It's a relatively fixed landmark. It is craniomedial to the cystic duct, as you can see, cranio and slightly medial. And the cystic artery is closely related to it. The cystic artery is closely related to it. Generally, we find it slightly deeper. Sometimes we have to take down the cystic lymph node to see the cystic artery. Again, a word of caution, try and remain lateral to the right of the cystic artery. Don't go medially. Because here, suppose the right hepatic artery is taking a turn, there may be a chance that it may be damaged. So just remain around the lymph node or lateral to the right of the lymph node, and it will be you'll be very safe in dealing with the cystic artery. If you see any pulsations over here, just make sure without clipping, before clipping, it is likely to be the cystic artery. It's likely to be the right hepatic artery. Once you clip the vessel and it pulsates, then it is likely to be the cystic artery. So in other words, a cystic artery never pulsates, usually never pulsates unless inflamed over a period of time before clipping. A right hepatic artery will be seen as pulsating. So one needs to remember that and be careful. Going ahead is the Rovere sulcus. And my advice is, whenever you come across a name, must go into, today internet is available, go into the history and pay our kind of respect to these great people. So Henry was a French anatomist, and the Rovere sulcus is named after Henry Rovere. And I think he lived from 1862 to 1942. And he contributed to a number of anatomical firsts, including the Rovere sulcus. So here you can see it very properly. It is about 2 to 5 centimeters long. It is on the undersurface of the right lobe of the liver, easily visible in about 80% of the cases where it remains open, partly or fully. It contains usually the entire right portal pedicle in the Glisonian capsule, or sometimes the branches. And during lap chole, it is best seen when you retract, as can be seen in this particular slide. The gallbladder has been retracted cranially and the neck has been retracted towards the umbilical fissure. And here you can see it very, very clearly. So what is the importance of this? You have to generally always remain cranial to it during dissection. If you're dissecting around this area, there is a good chance you may injure a right portal pedicle, either the artery or the portal vein, and they can cause torrential hemorrhage. And I have unfortunately been witness to one such case, and where the patient was saved with a lot of difficulty. So please be very, very wary of this and try to remain cranial to this particular structure. The other importance of the Rovere sulcus is that you can, if you draw an imaginary line called the R4U. So R is the Rovere sulcus, the roof of the Rovere sulcus, going on to the segment 4, base of segment 4, and to the umbilical fissure, which divides segment 4 from segment 2 and 3 to the left of this screen. So this R4U line, Rovere sulcus, undersurface of segment 4 and umbilical. So this line, again, the dissection should be generally above this line. Here again, you can see this is the Rovere sulcus, the undersurface of segment 4 and the umbilical fissure, and the area of dissection should be above this. So this will keep the Rovere sulcus safe and any other structure coming here safe. Again, with retraction, you can see this line very well. Another slide showing the same, the dissection, the posterior dissection of the peritoneal covering of the gallbladder. The dissection where we normally start our dissection, usually with the hook, is above the Rovere sulcus and the R4U line. And this is today's case, where again I wanted to show you the Rovere sulcus, which is partially closed, undersurface of the liver and going on to the umbilical ligament. And my dissection should generally be in this area. This is the same case which I had shown you earlier, where the gallbladder has been aspirated to some extent. Going ahead, the cystic plate. This is seen after we have dissected the gallbladder, but anatomically, again, a very important structure. What is it? It's a flat, ovoid, fibrous sheath located in the gallbladder bed. And this is a part of the sheath or the plate system of the liver. Medially, as we come, it continues with the segment 4 of the liver and with segment 5. So segment 4 here and segment 5 laterally, it becomes continuous with that. And as we go medial and superiorly towards the right portal pedicle, it becomes a part of it becomes thicker and become part of the portal pedicle or the Glisonian sheath. And sometimes in hepatectomy, we take the entire right sheath. So it becomes part of the cystic plate, merges with that thick sheath and covers it and enters the liver. We need to maintain as far as possible the sanctity of this cystic plate. The moment we go deep to it, superficial structures, the superficial ducts, or the superficial veins, which are the terminal starting points of the middle hepatic veins, or sometimes even arteries which are traveling superficially, they can start bleeding torrentially. Or if you get a patient and you have to operate on a cirrhotic liver, again, if you breach the cystic plate, the bleeding can be very, very difficult to control. Leaving this plate is also a reason why we go in when we get an incidental gallbladder, CAGB, incidental CA gallbladder, because this is very rich in lymphatics and you left it behind. In case the report is CA gallbladder, we need to go in and excise about 2.5 centimeters of this area, or a formal segment 4B5 hepatectomy. So it is important to remain close to the gallbladder wall while dissecting it off the liver and maintaining the sanctity of the cystic plate. And the breach can cause bleeding through anomalous right hepatic artery or the terminal branches of the origin of the middle hepatic vein, or an anomalous duct, usually the right posterior sectional or the sectoral duct. So this is the same case as I wanted to exactly show you. The moment you breach the cystic plate, you can see this red thing, which is not a good thing to happen. And in one odd case, you will find a small biliary radical or a bleed occurring. And this is the plate which we need to maintain. And in safe cholecystectomy, before we clip any structure, it is kind of mandatory to expose the lower third of the cystic plate and see that nothing else is turning back. In fact, as you can see, this may be a superficial vein, and the moment you breach the cystic plate, it may cause torrential bleeding. Very difficult to control. You give pressure and does not. The more you use cautery, the more it will bleed. So be very careful in dealing with this structure. Then this is the normal anatomy. Going on to the anomalies and the variations. While with these images, I wanted to highlight, while an anomaly or variation may be very obvious, sometimes it is not so obvious. And even with experienced people make mistakes, and that is how complications and biliary injuries happen in the most experienced of hands. And in 70% of cases where biliary injuries have occurred, the surgeon has not been able to pick up the injury at the point when it has occurred. This is well written, well illustrated in literature worldwide. And that is because even though the anatomy is there, the surgeon is not perceiving it well. And you must have come across this many number of times where they have tried to show how the eye gets tricked with because of a lack of perception. So all of you know, friends, that both these straight lines are equal, but because of the perception of the surgeon or the individual, one appears as longer and one appears as shorter. Similarly, in this particular image, both these lines are straight, but because of the posturing of the entire figure, they appear as curved. And this is exactly what happens in lap chole. And that is why they tell you to take a time out, ask for help, ask for another person before you clip or take a step which is irreversible. So going on to the anomalies or the variations. So in the cystic duct, which is one of the structures which you are going to tie or ligate or clip and cut. So normally it is 2 to 4 centimeters long. It is 2 to 3 millimeters wide. Enters the common hepatic duct at an angle, which is an angular insertion of about 75% degree, not percentage, sorry. And sometimes it may run parallel and go very low down and insert, like possibly in one of the pictures here. Or it may be spiral and it can actually go around and turn around and insert onto the left of the CHD. So that can create even more confusion. usually enters the CHD. It may be congenitally absent or very short, and again causing you to reach very close to you may have to clip it or suture it very close to the CHD. That's the only case where you need to go to the junction if it is kind of absent or very short or sessile gallbladder. It may enter the right hepatic duct, as can be seen. These are the variations which create the maximum confusions in the anatomy and most chances of complication, because you tend to clip the cystic duct here, and then you realize that this is probably a sectoral duct which is coming, usually the right posterior sectoral duct draining segment 6 and 7. Similarly, rarely you can have a duplication of the CBD, which personally I have never come across. And sometimes you can have a sectoral duct entering the CHD or the CBD, actually technically below the insertion of the cystic duct, creating even more confusion. These are very rare cases, but most of the injuries are done even with normal anatomy. So if you bare the cystic duct and cystic artery and create the CVS, or the critical view of safety, with only two structures entering the gallbladder, the lower third of the cystic plate bared, you're likely not to make any such mistake. So these are MRCP images. In Japan, it is mandatory to do an MRCP before you do a lap chole. Not so in India. Again, very high chance that the surgeon is going to clip this duct, thinking it's the cystic duct, but actually the cystic duct is entering possibly the right posterior sectoral duct. Again, in this case, there's a very high chance. And this is a classification given by a Japanese surgeon, which appeared in Surgical Endoscopy 2020. And this is an aberrant right hepatic duct. It can be the posterior or the anterior. And here you can see it can enter here. It can enter as a parallel, a third entry, a kind of a trifurcation, so to say, separately. And then if you're slightly above the gallbladder, you may find it separately. And here, as I said, entering inferiorly, creating even more confusion. And these two are kind of similar, the 1 and 5. Going on to the artery, which is the other important thing which you're going to clip before you go on to complete your surgery. And the normal anatomy dictates, normal means the most common anatomy dictates that the right hepatic artery goes posterior to the common hepatic duct and gives a branch, which can divide into a superficial and a deep branch, or an anterior and a posterior branch. This is the normal anatomy. I reiterate, if you see a pulsating artery in the hepatocystic triangle, it is likely to be the right hepatic artery, or a prominent right hepatic artery, or a bulge here called the Moynihan's hump. The cystic artery, before you clip it, does not normally pulsate. Remember that. So this is again the same case which was done in the morning, and here we found two arteries. And interestingly, this is a node, and this artery is in relation to this node. And there was another node here, and this artery was in relation to. But we made sure that these two are arteries before clipping them and cutting them. And this is the duct. As you can see, the CBD is seen here. This is the HDL, which is very important. I remained above the R4U line before we did any clipping. So, and we did not expose the cystic duct CBD junction. So in this one picture, I can convey a lot of things about the safe thing. I've not been able to show you the cystic plate, which was shown previously when in the previous images. Going on to the anomalies, here you can see this is how the right hepatic artery can bulge into, and we can tend to clip it here. As I said, this will usually be pulsating, and be careful. So go close to the gallbladder, you will be able to find a cystic artery taking off. Personally, I feel these dissections are best done with a hook rather than Maryland. Be very close and lift up each and every tissue. And with very good, a good HD system, you can see. Again, here you can see a very thick artery. Any structure which is unusually thick, both in the duct and the artery, make 100% sure that It is not the CBD or the CHD or the hepatic artery. Here again, you can see making a hump and going up. Last few slides. So these are the normal anatomies. You can see two arteries. In my case, there was one running here and one running superior and inferior. Then you can have it arising from the gastroduodenal artery. You can have it arising from the left hepatic artery. Normally, we don't trace it that much, but if you remain close to the gallbladder, you're unlikely to make a mistake. And sometimes it can be intrahepatic. You may not find any arterial, and they can find a sheath of vessels also. Again, if you're very close to the gallbladder, you are very safe. So, friends, to summarize, I told you about the 4 P's and the 2 E's, and the 5th P being proper retraction. This is what I tell my residents, and I keep reiterating it to myself. I told you, you should actually, not a good word to say, but you should have a roving eye inside the abdomen, have a look all around, see. You may pick up an incidental CAGB, you may pick up peritoneal deposits, you may pick up tuberculosis, you may pick up some other thing which can change your entire management. A very good thing to do. Patient may be symptomatic with something else. I myself have operated on thinking it's a symptomatic gallbladder, and turned out to be a jejunal CA causing partial obstruction. And eventually I had to go in again when the CT was done, and we had to operate again. The patient kept presenting with fullness in the abdomen, and we attributed it to gallbladder. It was a colleague's mother. So it's very important to see the colon, the duodenum, inflammation. Go on to the anatomy, like we do an ultrasound. We see for ascites, we see for metastasis. We go on to the, say, close to the pancreas, see the gallbladder. Similarly here, look at the HDL, the hepatocystic triangle, cystic lymph node, Roveus sulcus, R4U line, the cystic plate, and always stay close to the gallbladder, as I've shown. And the common biliary and vascular anomalies you should be aware of in your mind. What the mind does not know, the eyes does not see. So please have this in mind. Not to scare you, but once in your lifetime, you will come across this thing. And if you are able to save the patient, for that one patient, it is 100%. The complication, the morbidity or the mortality is 100%. Always remember that. Whenever you're operating on a patient, think of it as your own self or your own relative and what care you'll take. So that's my take-home message. Thank you for a patient listening. I'll be honored to answer any questions.
Yeah. Oh, there are no questions in the chat box right now.
Okay, sir.
Can
So
you see
any normal queries you would you like to highlight, which is good for the students, sir? And or anything which I have missed out on?
Yeah, the thing is very well covered. Most important thing, you showed the schematic diagrams along with the intraoperative photographs.
Yes,
in the anatomy, which is very important. See,
yes.
On the paper you draw and you see, but what you see inside may be little different. It may not look the same. So that was very important thing. The one thing which I found very important and interesting, which people don't emphasize on while talking about the anatomy of the bile ducts, is the relationship of the transverse colon, that is hepatic flexure, and the first part of duodenum.
Absolutely.
And we have to remember that these both can be injured, because in a patient who had a multiple attack of cholecystitis, both gets pulled towards the gallbladder.
Yes.
At their respective places, and can obliterate that area. So, and apart from the fissuration. So that was a very good point which you made, which these students should know, that it is not just the gallbladder, it is the other structures around it also have to be taken care of. And one should know the anatomical relationship with them. The second part, I can add one thing is differentiation between cystic artery and the hepatic artery is the size of the artery. You made a very good point that the pulsations.
Yes.
Okay. Cystic artery will hardly pulsate till you clip it and then cut it, and then you will see the pulsations, which are actually a transmitted pulsation from the hepatic artery. So if it is a pulsatile, yes. And then if it is anything which is more than 2 millimeter vascular structure, think of it could be right hepatic artery or the posterior division of the right hepatic artery, which is coming in the way. That's another thing which I would like to share with you. Now, as I've been told that some of the countries, they may not have the advanced laparoscopic instruments, or they may not be doing even the laparoscopic cholecystectomy. They may still be doing the open cholecystectomy. I think what anatomical things you told all of them, they apply equally to the open cholecystectomy.
Absolutely.
Except one point I would like to make, because the posterior surface of the hepatocystic triangle, we cannot see in the open surgery so well as we see in the laparoscopic surgery.
That's
So,
where, sir,
yeah.
fundus first can also be dangerous. I wanted to cover that, but since I was just covering the anatomy, we need to tell them that coming fundus first can be dangerous as you close on to the porta.
Yes.
So, because you directly attack, you are addressing the part of the hepatocystic triangle superior to the cystic artery, and sometimes you may lose track of where you are heading. As coming down with the cautery, you can actually injure one of the structures before realizing, and then come down onto the Calot's triangle.
Yeah, I quite agree with you. The fundus first should not be taken very lightly. Number one, you should draw the line where you will not go medial to that line while coming down from the fundus first. And to me, that line is, if you draw the line at 4B where the gallbladder meets, and you come down vertically towards the base of the segment 4 where it turns to the left. Okay. Before that, if you draw a vertical line, you have to be to the right of that.
Okay.
Don't come to the left, because the moment you come to the left, all the vascular structure and the abnormal right hepatic artery can come, right hepatic duct can come in the picture, and you can damage it while coming down from there. So that's another thing one has to look into. Dr. Kapoor, you want to add something?
Yeah. So, although in between, sorry, I missed some part because I was looking after some administrative work. But my suggestion to all young colleagues would be that before you jump onto the Calot's triangle, look around. That's very, very important. Don't straight away go to the cystic duct and cystic artery. Look around at the landmarks which have been mentioned by Dr. KJ Singh and are also mentioned in all safe cholecystectomy texts, which include the base of segment 4, which includes the cystic lymph node, if it is there, which includes the Rouvray sulcus, which includes the first part of duodenum, which includes the pulsations of the hepatic artery, which can be seen in a thin-built patient. They give you an idea as to what is the area where you should be doing dissection and which is the area which you should avoid. So by and large, the dissection should remain anterior to the Rouvray sulcus, to the right of the cystic lymph node or at the level of cystic lymph node, and definitely you should keep away from the pulsations of the common hepatic artery. Many a time I have seen young surgeons say that a pulsating artery is the cystic artery, but that is not correct. What one of the senior surgeons from Madurai, Dr. Ramesh Adnari, always is fond of saying, and I think he is correct, that undivided cystic artery would almost never pulsate unless it's a very elderly gentleman with severe atherosclerosis. Cystic artery will show pulsations only when you clip and divide it. Then the stump pulsates. So anything which is pulsating, presume that it is the right hepatic artery and stay away from it. Second is that in a difficult case where either Calot's triangle is not even what we call dissectable, or you have made some attempts but you find that going is difficult, then don't insist and persist with it. And this is the data we are now going to present in one of the meetings and going to publish also, that especially in our gallbladders, it is not possible and it is actually dangerous to try to demonstrate the critical view of safety. And you have to identify those cases at an early stage, then you move away from the area of presumed Calot's triangle, you go to the mid body of the gallbladder and do what we call a divide and rule. Open the gallbladder there, take out all the stones, put them in a bag in the subhepatic area. Now you look from inside what you are not able to appreciate from outside because of inflammation and fibrosis, you can see from inside. What you will see from inside, that the lumen of the gallbladder is going and narrowing into the opening of the cystic duct, or it is just closing. So that is the area beyond which on the right side, you leave about 5 millimeter or even 1 centimeter fringe of the neck of the gallbladder, do a subtotal cholecystectomy. Now cauterize the mucosa of this remnant of the gallbladder and either leave it like this with a drain if there is no bile flowing back, or try to close the cystic duct opening, or even try to close the remaining gallbladder. Always leave a drain. So subtotal cholecystectomy is a very good option rather than trying to do any other maneuver. And as far as fundus first is concerned, as was being discussed, sometimes fundus first also can be difficult and dangerous, because if there's no plane between the gallbladder and liver, either you will open into the gallbladder, which is okay, or you will go deep into the liver, and then when you move towards the hilum, you will injure the right pedicle. So biliovascular injuries sometimes can occur because of the fundus first approach. I think there are one or two questions, KJ, maybe you would like to take them in the chat box.
You very rightly said, in an inflamed gallbladder, sir, we follow this approach of going to the mid of the gallbladder, creating a plane either with hydrodissection or with other gentle measures, and then just opening it. Sometimes when we remove the stone, we are able to appreciate the Cowlitz triangle better. And invariably, as you said, sir, because of the inflammation, you don't find any bile coming back. And usually our practice is to kind of never blindly fire a stapler, open it and clear all the contents and then suture it with interrupted or continuous sutures and the same.
There is a question in the chat, and then Dr. Lamine has raised his hand. Maybe you can ask him.
Yeah. I think, Dr. Singh, one of the question is, what is the importance of falciform ligament in chronic fibrous cholecystitis with dense adhesions?
The falciform ligament.
Yeah.
Very generally, it is one of the markers that, as we said, it divides the segment 4 from 2 and 3. And unless it's there is an anomaly in the anatomy, it's a dextro case where it is going on. I've encountered one such case where it was going to the other side of the falciform ligament. Otherwise, even in an inflamed gallbladder, generally you have to follow the same principle as I said, that obviously you have to remain on the right of the falciform, much to the right of the falciform, and you have to follow the R4U line, which as we mentioned is the Ruvius sulcus, the undersurface of segment 4, and going on to the base of the umbilical fissure where the falciform ligament is. So unless you have something else in mind, you have to remain much to the right, even in an inflamed
falciform is too far
away, actually.
Yeah, because the person who put the question, I think one has to understand the falciform ligament is too far to the left, unless it is left-sided gallbladder. It is not going to come into the field of while doing the cholecystectomy. It is far off from there.
Yeah. Dr. Ishtiaq, you have asked what to do if a biliary confluence is totally cut. I think that was not the domain of Dr. KJ Singh's lecture. Dr. Yadav is going to cover it in the second part of his lecture, how to manage an intraoperative bile duct injury. Dr. Guy Lamine has raised his hand. Dr. Lamine, please come in and ask. Yes.
One more point in the previous question. If there is a atrophy, hypertrophy, in one odd case, you may have the liver rotated and the falciform seen very close to the gallbladder. Some situations can be there where, unless you've encountered one, where you can have a falciform close to the gallbladder.
Yeah. Dr. Lamine, Guy Lamine.
Thank you, Professor Kapoor. Hello, everybody. Thanks for all the tips and tricks that have been given. We really appreciate, because in our setting, we do not routinely have cholangio to be aware of eventual anatomical variation. So I think that knowing our anatomy is very important to have a safe surgery. So I have a question about some challenging situation while doing cholecystectomy. In case of strong adhesion between gallbladder and the surrounding structure, can be duodenum or right colon. How do you manage with this kind of situation when there is a fistula between gallbladder and digestive tract. Thank you.
So, Dr. Gail Lamine, I first wanted to ask you, have you been able to follow the lecture in the sense, was I audible and understandable? Was I clear in my diction?
अभी
Uh,
10-15 मिनट बाद
Thank for the question. Yes, it was quite clear.
Okay,
Even
okay,
if you
okay.
are French speaking,
Okay,
we
thank you.
understand.
Thank you for that. So, if you permit me, I'll just go back. In fact, I demonstrated that case. And with that presentation, I'll be able to show you. If I just go back to the slides. And I was telling you that this is the case which was done by my colleague, a very experienced and very, very competent surgeon just day before. And if I can just take you. So as you, very, very pertinent point. And since, as Professor Kapoor said, that I was not actually supposed to cover, so I didn't cover it in too much detail. So this is the picture that you'll normally get. This is that case. And if you can see a part of the gallbladder, I generally make it a point to hold it with a forceps, which has got a tooth forceps. No harm in doing that. If you are sure that you're holding the gallbladder. Sometimes it is absolutely not visible, in which case with the Maryland, gently take down the omentum and whatever is there without applying any energy. Give traction to the gallbladder cranially, and with the help of the Maryland, push this thing down, gently cauterizing whatever is the fibrous tissue, and which you're sure is the omentum. Generally, it is the omentum, colon, and as you go caudally and inferiorly, the duodenum. So very, very gently take all this down. It may take 1 hour, 1.5 hours, but if you are proceeding safely, please go ahead. If there is a fistula, you will be able to demonstrate it very, very clearly. And you will be able to fire a stapler. You can even cut it if your surgical suturing skills are good. I don't suggest use any thermal energy harmonic because it damages the thing more. Either use a stapler or cut it sharply with scissors and suture both the side on the duodenum. Here you can see how well he has dissected the cholecystoduodenal fistula. In this particular patient, he had both a cholecystocolic and a choleduodenal fistula. So there he's actually dissected and taken the colon down, and here is the cholecystoduodenal fistula. So gentle dissection, lot of use of hydrotherapy or hydrodissection with the suction and this thing. Keep putting water, saline, and these plain gently. That is the safest way which I use. Take all these additions down with the help of hydrodissection and gently with Maryland. You'll need a lot of patience, and I'm sure you'll be able to demonstrate both these things.
Thank you very much.
And we use a stapler to kind of divide them if well demonstrated.
Any other student wants to ask any question from Dr. KJ Singh? Rajendra, you want to add anything? Yes, please.
Yeah, there is something I encountered which was unusual. I almost had my first biliary tract injury. This was a medially towards the left deviated CBD insertion. In fact, it was very close to the falciform ligament. That was because the base of segment 4 was very narrow. So in this case, I tried to stay to the right of it and stay as far away as possible. And I encountered a thick structure, which I thought was the cystic duct, wide cystic duct. So we didn't have a stapler then, and the patient couldn't afford it. So we used 2 clips to close the thickened gallbladder cystic duct. Next day morning, there was bile in the drain. So I thought I have injured the common bile duct. We re-explored, did an intraop cholangiogram, and it turned out that it was just a subtotal cholecystectomy with the CBD coming almost 1 centimeter lateral to falciform ligament. This was one case. Another artery I had, which was an abnormality, was a small artery to segment 5. And this was in the bed of the gallbladder, and it was going right from the common hepatic artery to the, proper hepatic artery to the segment 5 all along the cystic plate. And there it dived in and went to supply segment 5. So these were the two encounters I had where I almost injured something and landed up in trouble.
Piyush, you want to say something?
Thank you, sir. Just a question. Sometimes when we have dissected the callus triangle and we found that the cystic duct is too wide, and we are sure that it is a cystic duct, and the clips, all the large, even the large hemolog is not, we are not unable to apply. So in that case, what do you suggest? Should we use a stapler or just cut and suture or tie it off?
I have absolutely stopped using a stapler blindly. And in a number of cases, what we have found is patients coming back with cystic duct stump stones or or gallbladder almost as large as the original one, and a number of such cases. So what we routinely do, one is, as Professor Kapoor pointed out, if you have had to dissect the gallbladder far away, leave a stump enough to allow, after having looked inside, after having that open approach, retrieve everything. You're sure that all stones have come out, all the sludge has come out, and only the mucosa is seen. Burn it safely and then fire a stapler. Even there, I prefer to suture it with the hand. That adds to your suturing skill. Now, the other trick, which again I am intending to write on and publish, is if you find it's not too wide, but it's not comfortable, then what we do is we either put we tie a free tie towards the medial aspect, then we half open the cystic duct. Yeah. We half open the cystic duct and milk it from near the CBD towards the cystic duct. And if any sludge or stone is there, which is slipped down, it comes up and shows up. So you can almost open the cystic duct half to 3/4 of the circumference and see a free flow of bile. Once you are sure that there is no stone and it is the cystic duct and happens to be wide, you can safely either take a tie or use a 400 clip or one of the other methods to clip it. So this is what we routinely follow whenever there is a cystic duct which is unusually wide.
The only word of caution.
Sir, if I could just finish, that in a significant number of patients, we found, even where we were not suspecting or there is no history of biliary pancreatitis where you anticipate, or a cholangitis that a stone has gone down, number of cases when you milk it such way where you have not suspected at all, you find that some sludge is coming back or small stones are coming back. So,
the only word of caution that whenever you encounter a wide cystic duct, 100% make sure that it is not the CBD. The first CBD that we divided in SGPGI was considered as a wide cystic duct, and the surgeon was advised to put a large clip. So you have to be absolutely sure, and then of course you do what Dr. KJ described. We also have Dr. Kotecha, who is a senior surgeon from Tanzania. Dr. Kotecha, you want to add anything? You want to say anything?
Thank you, Prof. It's been a very enlightening presentation. I don't have any other concerns.
Dr. Mathur sir, concluding remarks, and then maybe we will close, because we made it a policy that we will start exactly at 3 and finish exactly at 4, or we will.
There is one more question in the chat box.
And I made it sure to finish in 30 minutes as advised.
You can quickly answer that. There's one more question in the chat box.
Okay, yeah.
In what situations you lab chole intraoperative cholangiogram becomes very useful?
Intraop
Come again? What's the query?
Intraop cholangiogram. What are the situations where you think IOC can become useful?
Personally, not much experience. And actually, I've seen, if you follow the basic principles as described, trying to show the CVS, we've used ICG in a number of cases. That has helped us. Today, I'm not too comfortable using an intraop cholangiogram. So if any of the other teachers can enlighten, I generally don't encourage use, and we have ICG with us. So we tend to use that whenever we feel there is an issue.
Dr. Mathur sir, आपका muted है, unmute कर दीजिए please. Yes.
So before this ICG came into picture, okay, as a teacher in the KM, I used to do the intraoperative cholangiogram routinely only because so that I can train the residents how to do the intraoperative cholangiogram. and how to interpret it and how to take the picture giving the position of the patients. Because otherwise, suddenly you are faced with the situation where you have to do the intraoperative cholecystectomy. You have never seen one and you have only read in the books, it becomes very difficult to do it. Number one. Number two, where I had done it before this ICG came into picture was when I found that cystic duct was going upwards and opening into tubular structure where I thought it may be opening in the right hepatic duct. And there I wanted to be sure that what is going on there. And that is the time I did the cholangiogram, and to my surprise, it was a double bile duct. What the thing you were talking about. So I found the whole right system was going right up down to the papilla, separately from the left system.
So
So
I think one of the main
very few situations where you can do it. But
Wonderful.
I think one should practice it. If the ICG facility is not available, then one should practice it when it is not required to be done.
Yes.
So you know how to do it.
I think one of the major problems, and we've practiced it earlier, sir, but one of the major problems was in cannulating the cystic duct. Although the specific equipment used to come because of the Heister wall, straightening and entering the thing, that used to be a struggle. And transcholedocal with a needle, again, it has its own problems, sir. That's not a really advisable thing.
Okay. Piyush, maybe you can thank and close.
I think, sir, no remarks. You can just do a concluding remarks.
Yeah. So I think I would like to thank Dr. KJ for the presentation and Dr. Mathur for moderating. And all of you, we look forward to see you again next Friday, 3 to 4. And please pass on the joining link to all your friends and colleagues in whichever country you are joining from. Thank you. And my request that everyone please put your name and country so that we know from where students and surgical colleagues are joining. Thank you very much. Thank you.
Thank you, sir.
Thank you, everyone.
Thank you, sir.
Thank you.